Hi, my name is Simon Hanft. I'm a brain tumor surgeon at Westchester Medical Center in New York. And what I have for you today is a Connectome of the week. In particular, it's a low-grade glioma in a young patient in her mid-20s who presented with a focal motor seizure involving the right leg, which then generalized, and then imaging located this tumor. And the reason I selected this case is that there are really two reasons. One is that the tumor comes right up against the motor cortex, as I'll show you in a second. And utilizing the Quicktome software to clearly visualize the corticospinal tracts is one advantage. And the second aspect of the case is the fact that Quicktome displayed for me a network that I have not customarily associated with tumors in this region, specifically the default mode network, abbreviated as DMN. So let me get right down to the case here. This is an axial projection of the flare, and you can see at the very superior aspect of the tumor that we have coalescence of the corticospinal fibers here. And as I travel down the tumor, we can see that the leading edge of the mass appears to come right up to those fibers, but it does not appear to invade that aspect of the cortex. The fibers don't appear to be particularly displaced. There appears to be a small but meaningful separation between the fibers and the tumor. Now, if you're looking at this and thinking that functional MRI could provide similar information, the short answer is yes, but the more in-depth answer is that sometimes it's not as clear. Firstly, I would state that the Quicktome here very readily displays the networks and allows you to not only click and display the network, but to manipulate the network and its appearance in multiple projections, as well as allowing you to comb through the network at a very fine cut level and to really clearly see its relationship to the mass. I will also note secondarily that this patient, despite being young, cognitively intact, and motor intact, that the functional MRI was compromised by compliance, which is something that we often see. And that is not a factor here at Quicktome. The DTI is performed and the Quicktome will display the corticospinal fibers regardless of patient compliance. So it's a more reliable end result. I also want to emphasize the fact that the Quicktome software will automatically display for you the networks of interest. And that means that the software knows the networks that are in play with regard to your specific tumor and location. And so, sure, this is an obvious case regarding its relationship to motor cortex, the nuances being invasion and how close that involvement may be. But what's less obvious, or not obvious at all to neurosurgeons, would be the fact that default mode network is involved in this case. So the default mode network, which I'm going to click on here in real time and then proceed to scroll through, appears to be located, or a node of it, shall we say, is located along the anterior and more inferomedial aspects of the mass. Now, that area is an area that we're probably not going to be bold about in terms of resection. But I can tell you that in visualizing that network close to the mass, or closer than I had appreciated or expected, I was understandably more careful in that region of the resection. So, again, would I have been aggressive in that area? Probably not. But in having the DMN displayed this clearly to me, and this closely to the mass, it was an obvious guardrail for me. It was something that provided me with the appropriate level of restraint when it came to the surgical resection of the tumor in that region. What I'm displaying for you here is the immediate postoperative day 1 MRI. Now, of note, I have been obtaining DTI in standard fashion as part of my postoperative MRIs because I want to view these cases through Quicktome. I've been doing it on all cases. Fortunately, in this case, we did not have a deficit. I'm probably a little bit more interested when we do have a deficit because I want an explanation for that deficit that may not be obvious on traditional MRI. What I could show you here is essentially what you'd expect because the patient was intact postoperatively. We were able to carry the resection, as you see, really right up into that little nook, which is where you could appreciate some extension and perhaps even infiltration on the preoperative MRI. And importantly, you can see the corticospinal fibers traveling intact, not disturbed, clustered, essentially identical to what they were preoperatively. What I also want to show here is the secondary consideration of the default mode network. And as we begin scrolling down through the resection cavity here, we can see the parcellations of the default mode network. Now, of course, these are the lateral parietal representations, but the node that we had appreciated along the medial parietal bank here is preserved. Here are the parcellations all clustered right up against the inferior aspect, inframedial aspect of the mass. And so what I want to emphasize here as a take-home points are essentially twofold. The first is that we were able to very readily and easily visualize the corticospinal tracts thanks to Quicktome. It emboldened my resection and my own psyche, if you will, going into the operation, because I felt that based on Quicktome that there wasn't invasion to the motor cortex or the motor fibers, but I felt that there was going to be a plane that would allow us to carry the resection right up to the gyral bank of the motor cortex, which was in fact the case. And secondarily, a network that we have not traditionally incorporated into our thinking of these cases, which in this case is the default mode network, was something that I was able to respect and therefore not resect in this case. And I attribute that awareness to the Quicktome software, to the actual displaying of this default mode network, which I can then subsequently click on, display on the MRI with respect to the tumor, and say to myself, okay, that's some high-priced real estate there. We're going to be particularly careful when we get into that area. Thankfully, the patient had no cognitive deficits. We know about the motor circumstance, but there was nothing appreciable cognitively on our evaluation that would suggest any type of DMN injury. So hopefully those take-home points resonate with you, and that you agree with the utility of Quicktome in a case such as this. Thank you for listening.